Hi, my name is Holly, and I'm going to get started on the discussion 3 post. Um, for this one, we have to identify a topic from the readings from the textbook, relate it back to the topic of our toolkit, um, and then find a peer-reviewed article um, that relates it to our topic of the toolkit. So, the first thing I'll start off by saying is the topic that I chose was from our LAM textbook, chapter 8, and it would be on patient safety. Um, so, what I'm going to do is relate this back to my topic for the education toolkit, which is going to be managing chronic psychotic disorders. And so I'm going to talk a little bit about suicide in medical environments, so patient suicide that occurs in medical facilities. So I'm going to start by reading a quote from our LAM book on page 136. Care coordination interventions focuses on safe practices. They are targeted at reducing patient risk and improving patient safety in inpatient and outpatient settings, including the patient's homes, by involving the patients and their families, as well as providers and healthcare organizations. So basically, that quote is kind of stating the obvious that, we have to keep them safe on the unit and also give them tools to try to keep them safe while at home as well. And so basically, relating it back to the suicide prevention in medical facilities, basically by increasing patient safety in medical facilities, we decrease the risk for injury, therefore increasing overall better health outcomes for the patient. This can also decrease the utilization of healthcare resources. It can decrease the length of stay for the patient and decrease risk of liabilities from a healthcare organization if an injury or, God forbid, patient suicide occurs. Because what we know is that patient suicide in a healthcare setting is 100% preventable. One time is way too many because truly it is 100% preventable. If the necessary steps and interventions are taken to prevent such an act. And I found an article from the American Hospital Association talking all about suicide within the healthcare realm, and just a little bit on how to prevent it, whether you're in a non-psych medical facility versus a psych medical facility. So first I'm just going to start off reading a couple of statistics from the article. This was an article written by, let me see his full name again. His name is Chad Beebe. He wrote this in 2018, and he's the executive director of American Society for Healthcare Engineering. So, to start off with a couple of statistics, the CDC reports that suicide is the 10th leading cause of death. It claims about 40,000 lives per year. And the National Violent Death Reporting System, the NVDRS, in 2015 reported that 83 of those suicides occurred within the healthcare realm, healthcare facilities, which that number should always be zero because, like I said, it's always preventable. They found that mostly this was done by the patient hanging themselves on different fixtures within the healthcare facility. And this is an interesting part that the article pointed out that I never really thought of. I guess because I've only worked in psych facilities before. I've never worked in a non-psych area. But the article tells you the different standards, whether you are in a psych hospital to prevent suicide or a non-psych hospital or medical facility to prevent suicide. So to start off with the non-medical or the non-psych medical facility to prevent suicide, what you need to do, according to the article, is, you've always screen a patient for suicide with your interactions. Whether you should always ask the implicit question, are you thinking about suicide? Are you thinking about killing yourself? However, you can also pick up on things that they may say before that question is even asked. Just thoughts of hopelessness, no desire to live, nothing to live for, etc. And then you can kind of go from there. So those patients that are deemed, either having suicidal ideations or at risk for suicidal ideations while they're in the care of a non-psych medical facility, that patient automatically needs to be on one-to-one precautions. This means that the patient needs to be within arm's reach of a staff member at all times. If you're in a psych facility, according to the article, you need to have anti-ligature fixtures within your psych facility. It's unrealistic. It's virtually impossible to have every patient, every psych patient on one-to-one precautions. That just is not realistic. You can't staff that. There's not enough room for that. So when you're in a psych facility, pretty much all your patients are at risk for suicide. So you need to make sure that you safety-proof the unit. Ways that this is done, there's anti-ligature doorknobs, so patients can't hang themselves from the doors. There's alarms over tops of the doors that if there's any weight pressed on it, a very loud alarm will sound through the entire unit, and it'll tell you what room that's occurring in, the weight on the door. What else do they do? There's no attachment points on the beds. The furniture is usually glued to the ground. They have weighted chairs, which is more of just a safety risk in general, so people aren't getting hit with chairs. However, for the very acute patients, we do one-to-one for safety risk to themselves or others. So we also do that one-to-one intervention, but those are reserved for really acute patients, because if we did them for all our patients, any patient at risk for suicide, it would be the entire unit. So that's just not doable. So basically, to sum all this up, the article talks about for non-medical or non-psych medical facilities, patients at risk for suicide, which is going to be the minority, because they're most likely there for a medical reason. They're not having that, most likely not having that psychiatric component. So they have to implement 1-to-1 for those people. In a psych facility where 1-to-1 for every patient is not possible, you need to implement the safety risks, the anti-ligature, implement that throughout your entire unit. And then obviously screen for the acuity of the risk for harm to self or others, and at that point decide if they need to be a 1-to-1. Another thing that we do, which I talked about in one of the previous discussion posts in this course, is we have precaution level statuses for all our patients on psych units. The article does go over those as well, but just to recap those a little bit, a precaution level 1 is a 1-to-1 within arm's reach. A precaution level 2 is the patient has to be within line of sight at all times. And a precaution level 3, that's the highest that you can be on a psych unit, is the every 15-minute checks on a patient. So I hope that you guys have a great week.